Welcome back to Diabetic Foot Files, where we break down the science, the stories, and the survival of the foot or the feet, one layer at a time. So, if you haven't noticed, I'm going to do a marathon today because it's Easter weekend and I have to make up for lost time. So, today's episode is something that is quiet but yet deadly and something that doesn't scream until it's too late. We're going to talk about avascular necrosis, also known as osteonecrosis. And this happens when the bone loses its blood supply and begins to die. So the bone has no blood, no oxygen, and pretty much no means of survival. And in a diabetic population in that foot, it could be a ticking time bomb. So, what is avascular necrosis? AVN. Avascular necrosis, like I said, is the death of bone tissue due to the lack of blood supply. So think of the bone like a living infrastructure. It has vessels, it remodels constantly, it requires oxygen and nutrients. And without blood, the osteocytes die, the bone weakens, and the structural collapse begins. Common names for avascular necrosis is osteonecrosis, ischemic bone necrosis, bone infarction. So, where does it usually happen? The common sites for avascular necrosis is the femoral head, that's very classic, AVN, boards. The talus, for us podiatry, critical in foot and ankle. The talus is very common for avascular necrosis. Navicular bone, and the metatarsal head, think Freiberg's disease. In diabetic feet, the talus and the midfoot are especially dangerous because the limited collateral circulation, the high mechanical load, and then the poor healing environment. So, why does avascular necrosis happen? So, the core mechanism of avascular necrosis is anything that disrupts the blood flow. And we already know diabetes disrupts the blood flow quite significantly, correct? And anything that disrupts the blood flow to the bone, it causes bone death. So, what are some of the major causes? One is trauma, like fractures, like talar neck fractures. We know that very common causes the high risk of avascular necrosis. There's actually a classification system called Hawking's for avascular necrosis in the talus. So, I mean, if you're going to take your boards, please know that avascular necrosis, Hawkins, know all the different ones because it's the one that allows you to know the different types, right? And then the AVN risk. So Hawkins classification, type 1 is a non-displaced neck fracture. So AVN risk is 0 to 13%. So if you have a non-displaced talar, talar neck fracture, the AVN risk is 0 to 13%. Now, type 2 is subtalar dislocation. That's going to be a type 2. The risk of avascular necrosis goes up to 20 to 50%. If it's a type 3 subtalar and tibial talar dislocation, the AVN risk goes up from 20 to 100. Okay. And if it's type 4, which is subtalar, tibial talar, and talonavicular dislocation for talar fracture, AVN risk goes to 70 to 100, okay? So you see it's like a crescendo, right? The higher the number, the higher the risk of AVN. So just keep that in mind for your boards, okay? So diabetes. Diabetes, we have microvascular disease, we have glycation of vessels, we have poor perfusion. Small vessels feeding the bone become compromised in diabetes. Next is corticosteroids use. Okay, that is one of the biggest non-traumatic cases using steroids. We love some steroids in the foot to get some inflammation down, right? But we have to keep that in mind that that could cause AVN. So mechanisms such as like a fat emboli formation, increased osseous pressure, and reduced blood flow. Also, another thing that can cause AVN, avascular necrosis, is alcohol abuse. So the fat accumulation in the marrow and the vessels are compressed. Next is sickle cell disease. So sickle cells, red blood cells block microcirculation. So you have to keep that in mind. Next is a hypercoagulable state. So clot formations block the vessels. And then next is radiation or chemotherapy causes vascular damage and bone marrow destruction. So what's happening at the cellular level? So let's zoom in. So ischemic changes or ischemia begins. The osteocytes die within 12 to 48 hours, so it doesn't take long. The bone necrosis, the bone marrow necrosis follows. Then the structural integrity weakens as subchondral bone collapses. And then this would lead to joint surface collapse, arthritis, and chronic pain. So the key concept is the bone dies silently first and then collapse louder later. So let's focus on AVN in a diabetic foot. This is where it gets real. So in diabetes, we already know neuropathy is not our friend. It masks the pain, right? Pain is a signal and a protector, right? So patients keep walking on it because they won't feel the bone collapsing or the pain from the I believe there's some pain with avascular necrosis. Yeah, because you'll feel the bone collapsing as well. And micro trauma will continue. So combine that with poor blood supply, infection risk, and delayed healing. Now you have avascular necrosis plus the ulceration plus an infection that causes a very limb-threatening situation. So let's do a quick clinical scenario. A patient presents with midfoot swelling, minimal pain, aka because of neuropathy, secondary to neuropathy, no obvious signs of trauma. You would think Charcot, but you should also could think as a differential. That's the whole point of us learning differentials. We have to learn about all the possibilities that it could be with these presenting symptoms. But you should also think of AVN, avascular necrosis. So let's do comparison with AVN, avascular necrosis, versus Charcot. So, AVN, the blood supply is decreased. In Charcot, the blood supply is actually increased. That's why it's hot, red, and swollen. Might even have pounding pulses in Charcot, okay? Because the blood is actually washing, like literally washing the bone. It's so much blood in there, okay? Early on. Now, in avascular necrosis, bone death is certain, okay, because that's what it's called, osteonecrosis. But in Charcot, bone death is pretty much secondary, and then also it remodels as well. Remodeling is a part of the Charcot phase, right? So in avascular necrosis, inflammation is less in the early stages, but inflammation in Charcot is significant. Okay? And then in AVN, the collapse is progressive, but in Charcot, the collapse is quite rapid. Remember, the midfoot is one of the common places for the Charcot, okay? So, what are some of the signs and symptoms of avascular necrosis? Early on symptoms are deep aching pain if your sensation is intact. If the neuropathy is significant, you most likely might not feel that deep aching pain. You will possibly have stiffness and reduced range of motion. Late symptoms and signs of avascular necrosis, collapse of the bone, deformity, joint destruction. And like I said, in diabetics, the pain may be absent, especially if you have significant diabetic neuropathy. So you look for swelling, warm, subtle deformity, and non healing ulcers over bony prominences. So, how do you diagnose avascular necrosis? X-ray, you see the signs in X-ray if it's a late finding. They usually call something called Crescenstein, and that's subchondral collapse. MRI is the gold standard to diagnose avascular necrosis, okay? Because it detects early ischemia and it shows bone marrow edema. That's why I love me an MRI. That's why I say when in doubt, MRI it out, right? Okay then. So labs, not there's no labs that are diagnostic for AVM, but could be helpful. ESR, CRP, we already know these are inflammatories and help rule out infection, and hemoglobin A1C possibly just to know the patient's diabetic control, but there is no lab diagnostic value for AVN, in my opinion. Okay, if I'm wrong, please send a message, okay? Now, staging for AVN, okay? So there's something called the FIAC classification, FICAT classification, okay? So stage 0 is normal imaging. Stage 2, MRI changes only. Forgive me. Let's start all over again because there's 4 stages and the stages starts at 0. Okay, keep that in mind because there is some staging that starts at 1 and there's some stagings that start at 0. This staging starts at 0. So stage 0 is normal imaging. Stage 1 is MRI changes only. Stage 2 is sclerosis and cyst formation. Stage 4, no, stage 3, forgive me, collapse begins, and stage 4 is the final stage, arthritis. Treatment. Non-surgical treatment options for avascular necrosis is offloading. Offloading is very critical for avascular necrosis if you're doing the non-surgical treatment options. Reduced weight bearing, glycemic control, and bisphosphonates, kind of controversial, but keep up with the research when it comes to that, and then pain management. Surgical options. Early stages, they will do a core decompression that helps relieve pressure and improve the blood flow. In advanced staging of AVN, they will usually do bone grafting, osteotomies, joint replacements like hip or arthrodesis. I love me arthrodesis. I'm not gonna lie, especially AVN. Sorry, Osiento, but that's what I like. So AVN and ulcers. Let's think about the real world dangers. So when AVN occurs under a pressure point, the bone collapses, the skin breaks down, and then there's an ulcer formation. Now you have an open pathway to infection, unfortunately. And that what this can lead to is osteomyelitis, abscess formation, and amputation. So how do we prevent this? AVN. For diabetics, we would continue with the tight glycemic control, proper foot care, routine foot exams, early imaging if swelling is unexplained, and avoid unnecessary steroids. Because honestly, steroids do cause a lot of relief, but it's like a double-edged sword, okay? Because you have to remember steroids also suppress your immune system, okay? That's the whole point of the steroid working as well, right? It suppresses your immune system, so the inflammation and pain goes down, right? So that's why we would usually inject the steroids, right? To suppress the immune response or the overactive or overreaction response. So, what are some clinical pearls of avascular necrosis to keep on remembering? AVN, avascular necrosis, can mimic Charcot, so don't miss it. Don't misdiagnose. I should really do an episode on differential diagnosis and how we can work on that because that's like core medical school fundamentals because they teach you that like first year is I would think first year because like give you different scenarios. First or second year, but they give you different clinical scenarios and you write down all the differentials. Like there's not just one diagnosis, you have to rule out all the others, and that's how differential diagnosis works. That should be the core foundation and vocabulary of any medical practitioner, okay, in my opinion, okay, because we all know how differential diagnosis work. Could it be this, this, or this, or this, all right? Pain is unreliable in diabetics. MRI, early MRI can help save the limb later. Offloading is everything because remember you have to offload in Charcot anyway as well. And then if the bone collapse, it's pretty much like you might need surgical intervention most likely, okay? So, avascular necrosis doesn't announce itself. It doesn't come in loud. It whispers, and by the time you hear it, the bone has already collapsed. So, in diabetic foot care, that silence can cost a limb. So, we're just gonna stay vigilant, stay curious, and never ignore a swollen, hot foot. Okay, even if it doesn't hurt. Okay, because sometimes no pain is the most dangerous sign at all. That's what I know. Even pain, I think with time and experience, you'll learn to differentiate. But this is Diabetic Foot Files. I hope everybody liked this episode of AVN and hope everybody's enjoying their Easter weekend. And this is Dr. G. Take care of your feet because they take care of you.